Great, and well, I think it was a great set of topics that we discussed, and I hope you all agree. And we'll start taking some questions for our panel members.
Lovely panel, thank you. I have a specific question probably for Kevin and maybe Patty to discuss in a bit more detail this issue of what do you do, how do you manage, and what intervention or recommendations should you give to the young woman who is a adult survivor of having had Hodgkin's disease with irradiation to the chest, who has, for example, already had one breast cancer. And your curve where you show that the risk, just the plain old risk, much less the risk of another breast cancer, is overlapping with BRCA1, made me think, gee, are you recommending, for instance, that women who've had one breast cancer following treatment for Hodgkin's disease should consider prophylactic bilateral mastectomy, just like Angelina Jolie?
I'll answer it first and then get Patty's thoughts. This is a large population that we follow, and so the question comes in two parts generally to us. One is prophylactic mastectomy before a first breast cancer, and then the second is the contralateral prophylactic mastectomy for the unaffected side. We talk, we entertain the conversation, we go over risks with our women anytime they want to talk about prophylactic mastectomy prior to a breast cancer. And I have a couple of our breast surgeons that are really good at also going through the whole process with that. And I've only had one patient, interestingly enough, she was a BRCA2, her mother was BRCA2, and she was Hodgkin lymphoma. She elected to have it, and she had bilateral DCIS, fairly extensive, that was not yet picked up on imaging. We have a very sophisticated imaging group that really pays attention and looks to these and was not picked up. On the other hand, I am a firm believer, and I'm not a fence walker on the use of prophylactic mastectomy with the first breast cancer in the woman that was treated with bilateral radiation. Some of our women just had hemothorax or just an eccentric area. And I go over with them the risk of bilateral, and especially the ability, you're often lucky the first time. So when we reviewed all the records for the Childhood Cancer Survivor Study, we have the largest population of breast cancers secondary to chest radiation in the world. And we're actually looking now at DCIS predicting mortality as a first cancer. And I think when we finish it, we're going to actually show first cancer DCIS year mortality rate is actually pretty substantial because it's a predictor of them having invasive cancer in the unaffected breast if they don't have a contralateral prophylactic mastectomy. So we talk with our women, and the vast majority, in fact, do go that pathway. I think what Patty was also recommending as far as the SERM, there is an ongoing trial right now led by one of Smita Bhatia's colleagues at City of Hope, looking at the use of low-dose tamoxifen, and has a variety of different surrogate measures to see how that does. We also have an ongoing NCI-funded study to promote breast cancer screening in this population in women that are distributed across the country, U.S. and Canada, administered through the Childhood Cancer Survivor Study. So we're providing women with this information, and our goal is to basically, is what we said earlier, is to empower them, to inform them so that they can make the necessary decisions. I'll tell you one thing that surprised me. This moves away from your question, but it's still food for thought. I've been surprised that the low number of our women that are getting breast MRI, and I think cost plays a major role in that, but there's probably a couple of other barriers for their follow-up. So that answers your pre-first cancer and post-first cancer. And Patty?
I'm pretty much completely in agreement with Kevin. I mean, I wouldn't recommend preventive mastectomy to these women. Even in the BRCA1 and 2 carriers, that's a discussion that, some women just, want to choose that. If they saw their mom die of it, they're going to be much more interested in doing that. It kind of depends on where they are in terms of their own life cycle. So I don't think we're at that point, but I think intensive screening, I would certainly recommend MRI, and and we work to get it paid for in that patient population, breast examinations, and I think The biggest obstacle, I'm participating in the randomized trial with the low-dose tamoxifen, is these young women want to get pregnant or they're on birth control pills because they were made amenorrheic with their childhood cancer treatment, and they don't want to go off their birth control pills, and they obviously can't take that along with the tamoxifen. So many of the same barriers that we would see in high-risk populations for breast cancer primary prevention without this history are the same. And, tamoxifen is a drug that we know all, it's good, it's bad, and, whatever, and it's pretty well tolerated, and certainly the low dose is very well tolerated. But I think the idea for some people of having to actively prevent something, maybe it's a reminder that they're at risk, that, that they had this exposure as a child, the psychological, it's just been kind of amazing to me, because I think once somebody knows that they're a gene carrier, they are willing to take an opportunity to do something about it. They'll be monitored more frequently, even if they don't want to take a drug or have surgery. But I think there's a little bit of the head in the sand experience, and so whatever we can do with groups who are, doing social network activity and whatever, it is very frightening to know when you look at your risks of second cancers in childhood or AYA survivors, it's enormous, and, it's hard to face.
I would just make one follow-up comment about the use of tamoxifen or raloxifene or something in this population of women at risk after treatment for Hodgkin's disease. And I know there are trials, randomized trials that are going on. And I think Lisa Dillard, isn't she doing one up at the Farber? But I think we shouldn't just, say, well, we should consider and do this or use it off study or off label in a way, because we're talking about a fairly young population of women who, we got to balance. First of all, is it effective in this population as opposed to, other women? And what are the harms with long-term treatment? What's the balance of the risks and the benefits? And I don't think we know that. So until these trial results are available, I think we should be very cautious about recommending, oh yeah, well, take tamoxifen or something.
It's 5 years of therapy. We're not talking about lifelong therapy. There have been really good studies done in Italy with the 5 milligram dose, and there are no symptoms that occur.
Are these in the cancer survivor population?
Healthy women.
That's what I'm saying. There may be. Do you think the biology of the breast cancer is the same?
It's the same. That's what Kevin has shown in his studies. The rates of hormone receptor positive tumors are exactly the same. Tamoxifen reduces the risk of hormone receptor positive tumors.
I guess I'd have to say, show me the data, and we'll think. I mean, I hope it's available soon. Do you think it will be, or what?
Trial is accruing right now.
I'm going to take a question over there on this side.
Carol Hahn here representing the American Society for Radiation Oncology, and I'm at Duke. I want to thank the panel, very interesting presentations, and thank Dr. Offinger for his comments in terms of the role of radiotherapy in terms of curing these patients. We've learned a lot in terms of minimization of some of these late effects, but we certainly still have a long way to go. But certainly lower dose, more careful implications in terms of using radiation, especially in pediatric populations, have been really where we've been going to minimize these risks, as the panel well knows. It concerns me that in the earlier survey, only 2% of these AYA patients are being treated in pediatric facilities. So I certainly think we have a lot of these AYAs being treated out in the community setting. I agree that we need guidelines for algorithms to minimize late effects and follow-up, because we do certainly have patients at risk who aren't being followed. I also have questions about the fertility counseling. If only 2% are being treated in centers that may have access, do we know anything about the penetrance of that? Of who's being offered these options?
You mean what if they're just being treated out in the community? What they're
Correct.
Yeah, I don't think that there's a lot of information about who. But I think we know that even in academic centers that there's not full penetrance, even in places where you'd expect that maybe there should be. So it would be a hypothesis. I'd certainly say it's not full penetrance, and it's probably highly dependent on the interest level of the people who are doing it.
Right, because I think between the fertility and the screening, I think is a huge problem that probably has policy implications to protect these young survivors as they go on, because I agree they're very mobile, and they're not necessarily staying in their care systems.
Hi, Larissa Nekleroff, Harvard Vanguard Medical Associates. So as a primary care provider who's on the receiving end of getting referrals from a local cancer center of childhood and AYA cancer survivors, patients often come to me with a list of diagnoses, and primarily these diagnoses are acquired through screening. Most of these diagnoses are not associated with any symptoms whatsoever. And then the patients are also then seen by what I call an army of specialists. So what I wonder is that although we do need to screen for certain diseases, I'm concerned about whether we're doing more harm than good by overscreening these patients. And while I agree the guidelines are necessary, it's unclear to me how evidence-based guidelines in this area, whether they're feasible, because I think conducting randomized controlled trials, sort of going with the U.S. Preventive Services Task Force type of evidence that's necessary, is going to be very difficult, if not impossible, to get in this type of patient population. So I guess what I'm wondering is, within some of the data that you've already collected from your cancer centers or from CCSS, I mean, is there a way to look at these data among the screened versus non-screened patients and see whether there are any mortality benefits or any early diagnosis benefits, or are we really creating more harm than good?
So Larissa, we'll call that screenitis.
Yeah.
But you're exactly right. I think that there's both screenitis, and I think thinking about what those very troubling slides that Patty showed about all the CTs, there's reflexitis. So there's both some that's going screening and some things that people are worried about. Well, you've had it once. Could this be it, or something related again? I am going to highlight it again. Melissa's paper and JAMA really did a nice job where they applied the COG guidelines, and you can look at the yield of each of the different tests based upon the age of the patient population. Pituitary dysfunction is found early on. We see that typically early. Sometimes we see somebody develop their ACTH deficiency late on after their medulloblastoma treatment, but it's most of the things we see early on. But many of the things, the good example is that they found 13 occult breast cancers within a couple of years of screening in a young population. This is population age 33. But you also see a lot of abnormalities of lipids and stuff. I'll draw your attention to another paper that I think really answers the screenitis to lend, kind of point you in the direction I think we're going. There's a paper that we have in press with JCO that'll have an accompanying editorial where we look at the childhood cancer survivor study of the traditional cardiovascular risk factors and their interaction with treatment exposures. So these are largely their morbidities that developed after their cancer: hypertension, lipid abnormalities, diabetes and obesity, and smoking. And we saw a near exponential, more than additive model with the risk factors, 2 or more, when looked at with the treatment exposures. And hypertension was far and away, by far the most. Hypertension itself almost accounted for about 70% of that variance. Our preventive cardiologists that were involved in the study, again, start thinking, do you know how many patients that I just kind of go, blood pressure's up a little bit, but seeing that hypertension and the association with heart failure, with strokes, and with myocardial infarctions is actually quite impressive. In contrast to the breast cancer recurrence being the biggest threat to AYA breast cancer survivors, heart attacks and preventable second cancers that can be detected earlier are by far the most significant threat to a Hodgkin lymphoma survivor. And so I think that there's a very balance, but the need is for continued trials, like what St. Jude Life has done, like what other groups are. I think we're probably within 2 to maybe 4 years of being able to show mortality benefits in these areas. It takes time for the data to mature, to be able to look at enough mortality to have the right comparison population, things like that. But we've been looking at things that I think we're going to be able to do that for some different settings to be able to better answer that. But for the time period now, cardiovascular risk factors equal development of cardiovascular disease. We've aged these patients 20 years early, and I'm not as worried about that as I might be of the reflexitis of getting a CT scan for somebody that has a new pain. And those are the ones that really worry, because not only am I finding something that I may not have needed to know, but I am exposing them to radiation.
Right. I mean, I think the biggest ones are probably the echoes and the thyroid ultrasounds. I mean, I think, again, as a primary care provider, when I try to educate others, and I ask, tell them these are the guidelines, and they sort of smirk because we're used to really rigorous evidence-based guidelines. And they say, show me the data. Why do I need to get an echo in somebody who is, X, Y, and Z? So, I mean, I think with the cardiovascular, absolutely, we measure blood pressure, we check their sugar, lipids, I mean, prevention, smoking. I mean, so those sort of all go along with sort of normal kind of screening. And sort of management in primary care settings. But I think it's sort of like all of these other scans, CAT scans, echoes, et cetera, that I think we just need to get more of, an evidence base. That ASD, they might have had it from birth and never caused any problem.
That's right, beautiful. So let me, real quick answer. Thyroid ultrasounds, tell them no. We have brought that up multiple times in the COG, and we feel that thyroid cancer in somebody that's had radiation is an indolent process, just like it is in the general population. We have not seen any studies that shown a mortality advantage with early detection of thyroid cancer in this population, and that with a careful examination of the neck on a periodic basis, you're just as good. So the COG has explicitly not recommended thyroid ultrasound. Echocardiography, I think, is a wonderful area where in the next year or two, we have a number of longitudinal studies that are in process that are going to answer it. And I think you're right. I think that we probably do too frequent. And the key is we're finding out what that interval is. Is it every 2 years? Is it every 3 years? And I suspect that you can tell, especially by the time they get into the young adult years, most of the people's pattern, you can tell that you could probably space it out to certainly every 2, but probably every 3. But I'm going to wait a little bit longer before we make a more definitive statement.
If I could just make a really quick comment, I think the lessons that we've learned, the data that has been available and is going to become available from the Childhood Cancer Survivor Study and St. Jude's efforts are obviously critical to this, and we need the same thing for patients diagnosed when they're AYAs.
David?
David Fryer from Children's Hospital Los Angeles and USC. First of all, thank you for 4 superb presentations. They were really all very, very good and informative. I wanted to just follow up on Brandon's presentation to raise a point or create an opportunity to raise a point which has to do with the settings that you discussed. You showed data that being treated for Ewing sarcoma at a pediatric institution may yield a better outcome than being treated in an adult institution, but confounded with that, and probably something that should be raised in this conference, although I'm not sure I'm seeing it anywhere that it's going to come up on the agenda, is the issue of enrollment on clinical trials, which has been suggested to be a strong, 2 things, actually, probably a contributing reason for why the survival outcomes are lagging behind the improvement in younger and older patients, but also it may predict for better outcomes for individual patients. I think the data are getting a little older now, but still probably have a point to be made, which is that patients, it's been shown, I think, with Ewing sarcoma and perhaps other diseases, that patients treated at sites that where patients with these types of malignancies are treated on clinical trials, their outcomes are actually better than patients who are treated off, and that patients who are treated at institutions that offer clinical trials, even if they're not on the clinical trial, but they're at institutions that treat according to that standard, have better outcomes than patients who are treated at sites that neither on a clinical trial nor at a site that offers clinical trials. So I just wondered if you could speak to that point as perhaps relevant in the selection of a treatment for a given patient.
Yeah, I mean, I think I really appreciate you bringing the point up, and I guess what I look at is what we don't understand is what's different about those institutions. So you're right that institutions, whether they be academic institutions generally or pediatric versus adult academic institutions, sort of the rate at which they enroll patients in trials does correlate with some of these things. But what is that about that? Is it the ratio of staff to patients? Is it their tolerance of laboratory abnormalities and pushing forward with therapy. We really need to get to the details of what is it that's driving those outcome differences. It's probably not the size of the room, right? Or what, you know, so we really need to understand that. And I think that's one of the real opportunities going forward, is to be able to encourage the design of studies that are looking at those treatment details across settings. It's difficult to tease out because, you know, in some cases, for instance, adherence to therapy, you can record whether or not a patient got the drug, but it's more difficult to determine if they didn't, why. And is it a patient factor? Is it a provider factor? Is it some combination of the two? And so I think the design of those trials will be a bit challenging, but I think that's definitely a direction we need to go.
Hi, Jackie Casillas from UCLA. I had a question that arose when I was hearing Kevin's presentation on Tim Best's work on the radiation and gene interaction, and then also when Brandon talked about the exposure, the gene and lifestyle interaction, in the context that we have a very ethnically diverse population in the US that continues to grow, and what type of work is being done for our ethnically diverse populations and their risk for second cancers.
Zilch, not a lot. I mean, you know, as well as I do, Jackie, that's still, so each of the surveys that were shown earlier, where was the underrepresentation? And it continues to be a struggle. The ability to develop a genetic repository at an institution that serves a large proportion of minorities is actually cost efficient, not cost expensive. We've established a genetic repository in our high-risk program on there, and you can shelf origin samples for 2-3 years. The cost of analyzing is going down rapidly with that. And so the ability for you at UCLA, where you see a large Latino population, to be able to actually collect origin samples of kids as they're coming into therapy, or patients that are going into your late effects clinic, you have the ability to store that and then develop case control studies later on. For those that didn't read Tim Best's paper, the most impressive part is, for a major discovery, it took a discovery set of 96 cancer patients. And so it's actually a fairly small, I mean, that's still large, but it's still a relatively small discovery set, and the validation set was not difficult. And all of us think that the combination of that and understanding its interaction with tobacco or other lifestyle factors and exposures is where we need to go to really move towards that individualized or more personalized approach of long-term follow-up care.
Yeah, because I also think, just as a follow-up to that, you know, I know locally in our community, we have a CTSI at UCLA, and there has to be a lot of groundwork, again, with community-based participatory research and getting it out there to different communities of why this would be important, and being able to reach out, you know, to the communities, because I know that's an additional cost within research studies that I think is often thought about after the fact. And so I would just encourage us to think about it early on in our grant planning process.
Great. It's been great to see what a wonderful discussion we've had once again, but unfortunately we're done with our time for this session, unfortunately, and so thank you. Sorry.